Welcome to today's session entitled When Hospitals Deliver More Than Healthcare. Before we get started, I would like to go over a few items so you know how to participate in today's event. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you would prefer to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenter by typing those questions into the questions pane of your control panel. You may send your questions in at any time, and we will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grantmakers and Aging, and moderator for today's webinar. John?
Thank you, Kat, and thanks to all of you for joining us today. I'm delighted that you are able to join us, and we want to begin by thanking the 5-Funder Collaborative, which includes the Commonwealth Fund, the John A. Hartford Foundation, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation for the support of this work, as well as support of this webinar. I also want to thank Grantmakers in Health for their collaboration in this project. To improve the health outcomes and daily lives of individuals in the United States with the most complex care needs, these 5 foundations are working together to accelerate health system transformation. As a first step, the collaborative partnered with the Institute for Healthcare Improvement to create a dynamic website, The Playbook, Better Care for People with Complex Needs. Grantmakers in Aging and Grantmakers in Health have joined with the collaborative to promote the Playbook among funders and to create the new Invitation to Innovation initiative. People with complex health and social needs, many of whom face challenges such as chronic conditions, behavioral health issues, food insecurity, homelessness, and a history of trauma, often encounter a health system that is poorly coordinated, inefficient, and expensive. This group of people makes up just 5% of the population, but accounts for 50% of healthcare spending. The healthcare community is showing a significant interest in social determinants of health. But the challenge remains: how do health systems translate understanding about the social determinants of health into action and impact? ProMedica, a nonprofit health system serving 27 counties in Northwest Ohio and Southeast Michigan, has a strategic focus on addressing the social determinants of health. Joining us to share that journey is Randy Oostra, the President and CEO of ProMedica. Welcome, Randy. As was mentioned earlier, we will be having your questions at the end of the presentation part of this session today. So please enter those at any point in writing, and I will ask those after the presentation begins. So Randy, let's start in the presentation. As you have mentioned before, a lot of organizations are now talking about the social determinants of health. And tell us about what you did to bring ProMedica to the fore of national hospital systems in bringing this to actual fruition.
Great, and good afternoon, and yeah, happy to do that today. So what I thought we'd do is kind of go through our 8-year journey, and we have a lot of slides, but they're important because we all kind of come at this from a little different perspective, but it's a bit of a story of where we started 8 years ago. We never just, decided we would be at this point in life, but the more we did relative to connecting the social needs of people with the clinical needs, the more that we would say today we have a long ways to go as well. But what I want to do is just kind of talk about kind of our approach and our thinking and how we've worked through our board and gotten board support and physician support and really where we're at. So, how we like to talk about it a lot of times, especially for folks that may be new to the topic, is the first slide really puts up a slide that talks about a health system. And it's got numbers on there that talk about sites and numbers of hospitals. It shows that, an organization that employs 1,000 providers has a health plan, which is somewhat unique in healthcare, has lots of activity, both on an inpatient and outpatient basis, does a lot relative to community involvement, and oh, by the way, has assets, revenues, and ratings that would put them in the top 15% of the country from a rating standpoint. So when you ask people, what do you think of this health system? They would most likely, especially healthcare people, would say, pretty good, doing a good job. You really got a nice, solid health system here. So the next slide on page 5 really talks about a community. So if you were in a community, and we like a lot the Gallup WellBeing Index, and your community was 99th out of 100, and 70% of adults are overweight, significant issues with food insecurity. In your state, you're in the bottom quartile for health outcomes. Huge race disparity, extreme poverty in the area you live in, issues with depression, children in poverty, homelessness amongst the public school system. And what would you say about that community? And I think we'd all say that is a community that has significant issues, significant problems. So I think you know where this is going. So the next slide just says, well, what if it's the same community? And really what you're seeing on the left side is this notion of ProMedica, and those are our statistics and numbers. And on the right side is a profile of Toledo, Ohio. And this is the American healthcare story. So if we took the left side of it and we went into healthcare circles and rating agencies, we would be patted on the back, told we're doing a great job. And yet you walk away 3 blocks from our hospitals and you begin to see the things on the right side. And so this notion is, when we begin to think about all the changes in the American healthcare system and the issues facing us, do we really have this right model in healthcare? And we'll kind of develop that today. So Jim Collins, of course, I think you've all read Good to Great in the social sector. So he wrote Good to Great, great book. Lots of people studied it. But the better book, of course, was Good to Great in the social sectors, where he asked us all to think in terms of the impact we make relative to resources. So we all have different resources, organizational resources, personal resources, and healthcare has tremendous resources, but we've never tapped those resources for many of the social needs, in our country. And so I'll kind of fast forward here a little bit. Our view of the world is that every hospital in the United States should be required to screen for social determinants in a fair amount of time, in a certain time frame. And also, by the way, we should be reimbursed for risk-adjusted social determinant clinical outcomes, and hopefully we'll be able to move toward that. So, we now then, if you go to the next slide 7, you really see the notion here that this impact then is really, you need to put the boxes together, and that as healthcare, and especially as the role we play in our communities. So ProMedica has 13, 14 hospitals. We're in a variety of communities, and we are the largest employer. And we have tremendous resources, both economically and resource-wise and people-wise. And if we don't begin to use those resources in addressing some of these social needs in our communities, and our thought is like, who else is going to do it? Is it the local governments? Is it the city government? Is it the county government? Is it the local United Way? Or is it other organizations? And the answer is yes. It's all of that. But again, just given the resources we have to take a much more stronger role. And then again, you can go further. And the next page really shows not only is it the responsibility of healthcare, it's the responsibility of every company as well. So when you look at community issues and you look at your health system, our perspective, and it's also as an individual, our personal, role, and also our organization's role in what are we doing to make communities a better place to be. So you probably all know about Gallup's book, WellBeing, and of course the 5 interrelated elements that they say makes well-being in life. And so many times we've treated clinical care, but we haven't necessarily thought about this notion of well-being. So the last few years we've become very enamored with Gallup's work, this notion of career well-being, loving what you do every day, social well-being, having those relationships in life, financial well-being, the security of finances that we have and the ability to afford the things in life, physical well-being, which include physical and mental health. And then this last piece is really this notion of contributions. And it's interesting, in the latest round of Gallup, the 2 things that have gone down, and for the first time since they've taken it, and actually all of the well-being indexes have gone down. And really where we see the biggest reduction is in purpose and social interaction. So if you kind of think about that from some of the things going on in our country, that makes sense. And then finally, what Gallup would say, the difference between a good life and a great life is this notion of community. And as this slide talks about, what we are all about is creating community. And that community is this vital place that we want to live. We want our children to live, our grandchildren to live, and really kind of create this opportunity for everybody to achieve the level of health and well-being that, we all want people to achieve. So, the American healthcare situation is a mess. I think, most of us would be fairly pessimistic that it's going to change in any way, shape, form on a radical basis. There are a lot of things going on that are positive. The Affordable Care Act provided some, coverage for folks, but really didn't do a lot to change the model. And what's interesting about the healthcare model, and we could go back and trace the history, we built the American healthcare system. And every president, if you go back to probably the 1930s, every president has said that healthcare is a problem and we need to get our arms around it. And you really see with, the issues of Social Security and the notion of trying to take care of Americans who didn't have any form of health insurance and they retired. And Hill Burton, which built about 200,000 beds in this country, that's 4,000 50-bed hospitals. And there are a lot of small hospitals in this country. Well, we built that with Hill Burton money. And the reason for that is pretty straightforward. It's one of these war events. People came back from World War II. There was great improvements in healthcare. We had people coming back from the war. We put them to work. And oh, by the way, what better thing to do in America than build hospitals? And we did that, and you can kind of see we're at 5% of the gross domestic product in those days. And really what began to happen over a period of time is that we made a variety of changes, providing a social net, Medicare and Medicaid, but also perhaps if we could go back and change some of the reimbursement, decisions made in those days, the old notion of you get what you pay for. So in a fee-for-service environment, how healthcare was traditionally paid, if you are paid to do something, you do it. And so we have tremendous amounts of work and activity and facilities that were built across the country, which Medicare paid a lot for, by the way. And we built an American healthcare system. And now as healthcare has changed, we have a lot of healthcare facilities built under a model that we can no longer afford. And so now we're looking at, moving from, 17% of the GDP on the way to 19% of the GDP and predictions over 20% of the GDP. And really the bottom line of that is the impact on people. And on page 12, we really just get into that, and it's the things that you know about. People not being able to afford basic care, people skipping prescriptions and other forms of care, number one cause of personal bankruptcy, the lack of many of the type of services that would be most impactful to people from a day-to-day living. We see people whose incomes are not keeping up with inflation relative to healthcare, so healthcare is eating away any sort of increase they have in real household income. We have seniors living below the federal poverty line. We see inequities in care. We have some fragmentation in the system. And oh, by the way, Medicare and Medicaid continue to grow. And so the idea there is we're going to continue to see issues relative to healthcare. So, it's a bit of a mess. But what we believe and what we advocate for is this more socially based model. And that one way, form, or another, we pull healthcare more into this social determinant world. Kicking, screaming, encouraging, paying, however we do it, it's an area that we really need to do. What's interesting about success, and the next slide talks about success, we have in Ohio some great healthcare systems, names that people would know. We have some of the best children's hospitals in the country. And yet, when you look at our statistics, you would say, what the heck? How do you have all these great hospitals and health systems? And you were 49th for infant mortality in America and 50th for African American babies. And oh, by the way, you have significant issues. You rank really, really poorly. And again, the issue here is not that we don't have great hospitals and beautiful facilities and great caregivers and dedicated professionals. It's just Ohio is a state with very significant social issues, as well as Southeast Michigan, where we are. And yet we spend $3 trillion, $3.2, $3.3 trillion in this country on healthcare, and yet we underinvestigate. And so really, what is the notion of success? So what happened about 7-8 years ago is we did a community needs assessment. most systems, large systems, did those prior to the Affordable Care Act. I personally am a bit of a cynic about community needs assessments, and the reason was we always did them prior to the Affordable Care Act. And we do it, we'd create something, we'd say we should do these nice things in the community, more random acts of kindness, if you will. And then toward the end of the year, we'd say, what did we ever do? And we'd pull out the binders and take off the dust and kind of think about what we did. And, now we still continue to do that, and they're very high level in their community, but really I'm not sure it puts enough action, boots on the ground, the intention that we need to really make the type of action that we need in this country. So 8 years ago, we decided, you know what, we have these huge issues relative to obesity. Let's go in and train, parents and children how to eat healthy, kind of like we did with smoking. So our system invested almost $500,000 in maps, very large, well-done tabletop learning maps with a company that does this all around the world. And we created maps for children, before preschool, early elementary, middle school, high school, and then companion parent maps that go with it. We had this whole discussion about nutrition and diet and healthy eating. And we did that. We pushed them out into schools and Boys and Girls Clubs, and we worked with the United Way and did summer programs. And what happened after we'd done that for a few months is we got a request to meet with some of the trainers. And their issue was, listen, we have a problem, and the problem is hunger. And we're like, what? And they're like, hunger. These kids are hungry. And it's like, well, we didn't sign up for hunger. We signed up for training. And really, what it led us on was a journey to start to look at the impacts that hunger has on health. And as my kids would say, well, duh, it took you so long to get there. And that's what the hunger community told us as well. So we began to show up at the USDA, and we went to a whole variety of organizations. We went to the agricultural department and their faith-based part of the agricultural department. We went to, Share Our Strength and Bread for the World, the Alliance to End Hunger, food banks. And really what we found out is that hunger is a major health issue in this country. And the next slide just shows some of the huge impacts of hunger. So we choose to make it a welfare issue, but this is one of those issues that healthcare has just traditionally ignored. And so what happened from that hunger work, and the next page just shows kind of the game boards and what we used. We got we were impacted by this hunger story. And we started out by looking at hunger. So many of you know some of the percents relative to food insecurity in the United States, around 13%. Almost 20% of households with children are food insecure. 30% of households, single moms and children, are food insecure. For a family of 4, that means they miss 100 meals a month. Seniors, they believe, are 30+%, a little concerned about whether or not they will report accurately. High numbers, of course, in undocumented workers, extremely high levels from people coming out of prison. And really what you start to begin to see, and what we saw in Toledo, Ohio, is that we have a major healthcare crisis with hunger. So since then, we began a series of steps. We started to learn a lot, people that had been in the space before us, people that, the screening questions we could do. So last year in our system, and this is kind of a rolled up synopsis of what we're doing, we screened over 500,000 patients last year, and our goal is to screen every inpatient and outpatient that comes in our facilities. Along the way, we created food pharmacies where physicians can write prescriptions, and you can see that we've served almost 30,000 people last year with food pharmacies. People that maybe wouldn't go to a food bank will listen to a doctor when they tell them to go to a food pharmacy. We have pre-packaged food bags in our primary care offices, so if a employee feels that somebody's in need on the spot, they can give them food on the spot. We found, again, as we started thinking through other issues, a certain percent of our employees live below the federal poverty line, so we even have some of our employees that have needs, so we provide food assistance for our employees. We don't pre-screen them, we don't ask them questions, we don't want to see their paycheck, we just give them food. We provide meals at discharge when we believe there's an issue. We started a food reclamation program, and so we have people that go into venues that prepare food that's not served, And over the last couple of years, we have reclaimed about 300,000 pounds of food. Now, let me just add, we get that that doesn't solve poverty. That doesn't solve a person's hunger, but it does practically at least allow us to, reclaim food. One of our hospitals, our children's hospital, is a summer feeding site. And oh, by the way, we mapped our communities for food insecurity and food deserts, and we started to think in terms of a need for a grocery store in the northern end of Toledo. And a donor who heard us talk about it said, if you want to do that, I will help you. And long story short, gave us several $1 million to build an inner city grocery store. We hadn't planned to be in the grocery store business. We went to all the chains, both big chains and local smaller owned facilities, and no one would help us. So we went into the grocery store business in a part of town that is had some issues in life, and we've been operating it for the last couple of years. Actually, last year it broke even, so it worked out really well for us. So we worked hard to make this a process that works for us. So we screen through paper or iPads, or if we need to do it in person, we tried to not make it a burden on caregivers. The next slide just shows we went to Epic, one of the major computer companies in healthcare, probably has the largest market share, and we worked with them to embed these screening questions and kind of the whole process that you would do this into Epic. And it's a shared sort of knowledge base, so anyone in Epic would be able to see what we did and what we've done. And what's interesting, and this is kind of the growing proof that we have that these things matter. The next page just shows the difference from people that that have screened positive for food insecurity, those that went to a food pharmacy, and those that did not. And as you can see here, when you look at the differences in cost, the cost is fairly dramatic, different. So this notion then that doing these social interventions are going to keep people out of our hospitals, they're going to keep people from being readmitted, they're going to keep people from, ending up in our emergency rooms, and that's exactly what we've seen. So in pilots, one pilot with 4,000 Medicaid members, we had a 3% ER reduction, a 53% reduction in readmissions. That means people that have left the hospital and go back within 30 days, many times because of issues, maybe not caring for themselves or having resources to do that. A 9% increase of people actually being encouraged to go to their primary care. And what we've seen in other pilots is saving somewhere between the 25 to 30% range. And so we believe, and I'll talk more about it, this is this whole notion of what we believe, is really going to kind of make this the proof that we need to do this everywhere in the country. So the next page just goes into this whole thought process about, we are asking the wrong questions in healthcare. We ask people all sorts of things, and we talk to them about a lot of things, but we don't ask them sometimes about mental health or food or neighborhoods or toxic stress, or whether they can read, or whether they have transportation, or whether they're a victim of domestic violence. And, those are the sort of things as we continue to roll forward, those are the things that we're going to be looking at. So the next picture is really kind of a notion of our journey. And what this slide tries to tell you, and I'll just give you some highlights here, over on the kind of the left upper quadrant is really kind of this notion of the last 8 years and this path, and really beginning just to question the basics of healthcare, just like what business are we really in, and what about this notion of health and well-being? And then it leads us to do a variety of things in the hunger area, and I think I've clicked through a lot of those statistics with you today, but also a realization that, in many of our communities, they aren't growing. And so our role as an anchor institution, we talk a lot about anchor institutions anchored in place, schools, hospitals, maybe some businesses, and their ability to look at tenacious problems. So we don't have a lot of great examples in healthcare, although it's building, and it's really being able to use the resources and people of healthcare to address these issues. So, it's not the purpose of talking today necessarily, but we've done things like we're moving 2,000 of our system employees into inner city Toledo. And I can tell you we have 1,000 there. We've got another 1,000 we're moving. and that has had a huge economic impact on our downtown and has really kind of set up a whole renaissance. Our board has allowed us to make some non-traditional investments in things like buying a bankrupt hotel, trying to find someone to develop it, which we did. That bankrupt hotel was sold to a developer from Chicago who spent $30 million and turned it into a Marriott Renaissance. We bought 75 acres from some Chinese developers, and it's being sold to folks that are turning it into 200 apartments with a retail complex and some restaurants, and then also a metro park. So in both of those cases, we are getting our original investment back. So we kind of like on HGTV, we're flippers. So if we can get in and get out. We've done those two big projects. We bought a 150,000 square foot retail complex, which we've bought from a gentleman in California who wasn't doing much with it, and we have since sold it for what we paid for it to a developer. And so our board has allowed us to do a number of things like that, and we've done a whole variety of investments and things to spur economic development, because it goes with our thinking about social determinants, and that the best thing you can do for a person is help them, get a great start in life, healthy moms, healthy babies, the right things before they go to school, health during school, and then, oh, by the way, culminating in a job. What it goes on to tell us is that we, along the way, have partnered with AARP to form a national organization called the Root Cause Coalition. We have 50 national members. I'll talk about that in a little bit. We continue to look at some of the clinical things we're doing, and then Mr. Ebi gave us a very transformational gift, which I'll talk about in a little bit. The next slide is just one for some of the boards we talk to. It's about our mission, this whole notion of the why. Why do we exist? What do we believe? So sometimes we talk to boards, they're like, are you sure you can do all this? And it's like, well, hey, it's our mission. We can do what we want, and it's why we believe we exist. We always put in the next slide about clinical excellence, and we're like any other health system. We do a variety of clinical things. The three mantras in healthcare: first, keep you safe; secondly, heal you; and the third, be nice to you, in that specific order. So the reason we put that in there, so people always, we can emphasize to people, we know that's our job. We get that, but we also believe this other job's important. Many of you know about the factors of health and well-being, and this fact that we pay $3 trillion for 20% of what impacts your health. Makes sense for those of you that aren't used to the social determinant world, and that the rest of our health and well-being is really by societal, economic, behavioral, and environmental issues. And so we spend $3 trillion, many of which we'd have to question some of the investment in the 20%, and then we don't do many of the basic things in life. And so those are the sort of things that people are paying more attention to. So most healthcare people now say they do social determinants, but because it's a buzzword, but yet when you ask them what they do, many of them do very minor things and not the type of things that you would expect that they could do. So we still find on the next page board members and hospital types that would say, hey, it's not our job. What are we going to do? You want us to follow up? I might get sued. I don't have the money. I don't have the staff. I have other priorities. Aren't you just boiling the ocean? We hear that one a lot. And so, but the notion is no, this is really what we believe should be the American healthcare system. So the next slide just shows you a picture of the market on the green. It's called. That building was an empty building that the city of Toledo gave us. The first floor is a supermarket. The second floor, you see a teaching kitchen there. We have a teaching kitchen. We also have several training rooms where we train people to be nurses' aides. We also have a financial opportunity center of the NEKC model that is in cooperation with LISC. And then on the third floor, one of our board members, who's in the call center business, has 60 individuals that he hired and pays for their training. And so they are working, they do student loan and healthcare collections. And he's created 50, 60 jobs, probably has the ability to create hundreds more, $15 an hour with benefits. And I believe it's either 4 or 5 of his employees, he's a very mission-based sort of guy, have been homeless in the last year. So it's this idea of helping people, providing some resources, and try to enable them to make some changes in their life. So Mr. Ebi was very positive about it. So the next job just talks about this company called Credit Adjustments. We actually invested in this company so they would be able to expand in our market. We normally don't tell people that because it's not good for a healthcare company to say they're in the collections business. But we made an investment, and the investment there was, again, to be able to help people create jobs. One of our incentives for us in management is this job creation idea. So our incentive compensation is based on job creation, non-healthcare job creation. So that's really kind of explains a little bit about our board. I mentioned the Financial Opportunity Center. That's the KC Foundation model. You can see, I think many of you probably are familiar with that, the type of things that they work with, helping people get out of predatory lending, establish bank accounts, credit scores. And you can begin to see there's some of the statistics for yourself. So we made a huge impact. We're going to be expanding that. We also believe that this is the type of thing we should be providing for our own employees in more depth. And also, we believe that all employers should provide that. So Mr. Ebide was very generous. So we began to talk to him about other things. Very generous man. And he was getting toward the end of his life. And he gave us some additional monies to start kind of a Geoffrey Canada, very intensive model in this uptown neighborhood. That's the area it's the area around the grocery store. It's called Uptown. And he gave us $28.5 million that our system rounded up. And so we have this $50 million 10-year commitment to a certain geography where we are really looking to create a national model to revitalize this community and really change it in a very radical way. And so we've hired significant amounts of people to do that. And I think I'll come back to the list. On the next page, it talks about the people we've hired or in the process of hiring. So in this neighborhood, we will be providing 27 new FTEs, financial opportunity, community health workers, community builders, folks doing job coaching, people working with homelessness and senior services. So really his gift has been really this transformational gift. And we have pledged the Ebide family, certain metrics. So the next page talks a little bit about some of the metrics that we are tracking in housing and health and jobs and education and safety. So we're definitely trying to track these metrics as well as the health improvement of the neighborhood. And again, you can kind of see on the next page this whole idea of this uptown neighborhood and kind of there's some characteristics about the neighborhood. So the LISC, the Local Initiative Support Corporation, heard about the Ebide gift, and they said that they would try to match it. And so initially, what we've created, we have put a $10 million. They put in 15. So we have a $25 million loan pool that we have created with LISC, primarily driven toward economic development, minority and women-owned businesses. And the goal there is to grow the 25 million through a variety of resources, anywhere from 50 to 100 million. And then also there's a $10 million grant program. Now this is available to a larger geography. So again, something that we weren't expecting. Since then, a number of banks have come alongside of us and are looking to invest additional monies with some staffing to help economic development in really kind of staff economic development positions that would help people access money and then really do things with the money. We've also tried to, think about research, kind of the holy grail here is to be able to prove to people, we've done enough work where we've been able to show some things. But really, as we screen people, one of the beautiful things here is we have cost data and we have data. We do have an insurance plan. So when we identify people and we do social interventions, we're able to begin to tell what impact it has on their costs and what impact it has on their lives. The difficulty here a little bit is when you have people that have multiple issues, and which happens often, how you begin to address certain issues, how do you do studies. So we just hiring our first national social determinant research director, and we have a whole variety of things that we're doing relative to research because we think it's critically important. And the next page just talks a little bit about some of our research efforts. I mentioned the Root Cause Coalition with it says 40 members. It's actually 50 members as we speak. Our next conference is in October in New Orleans. And again, that's a sponsorship that we have with AARP. And again, it's just getting a lot of more interest. It doesn't have a lot of C-suite sort of attraction yet. When I talked to the folks, Don Burwick at IHI, and I mentioned that to him one day, he said, don't worry about it. Just build it from the ground up and it will work fine. And that's how they built IHI. And we talked about them earlier. So social determinant screening, we've moved on. So now we are in the process of expanding from hunger to screening for 10 social determinants. And we're in that process. It gets a little more complex. It goes a little slower. So we've had 28,000 screens with the 10 social determinants. It's easy to screen. It's the interventions and the tracking and just making sure that we get people to the right resources is the hard part. So again, you can see the screens. You can see some of the impacts there. And again, I think what we're seeing is people having multiple issues in their lives. But what's interesting, and this is where, when you hear certain politicians talk about those people, when we screen people and we ask them motivational questions, 87% of folks have a high motivation score to change their life. And they just don't know how or don't have the resources to do it. And we think the percentage is actually higher than that, than the 87%. It's just, I think sometimes people aren't reluctant to really just say what they're thinking, and they probably could be embarrassed. So the next slide just kind of shows a new pathway, and it's this idea that we need to really think more globally about health, which you all know about, and it starts with healthy moms and healthy babies, and really goes through this whole process. I go back to this infant mortality in Ohio, and how does this happen, and the fundamental work that has to happen to make sure that we address those things, and then just this whole picture in life and where we go. So our budget is around $8 million for this work. 7.2 million of that is really through this, either through foundations or grants or the gift from Mr. Ebide. So our system today, and again, I used to say we only were spending $50,000 a year. We're spending a little bit more 8 years later. So it is closer to $800,000 to $900,000. I will tell you that even some of our board members have given us gifts in this regard. So we do have a fairly significant investment, and at this point, I would say we just continue it to grow. The next slide just talks about anchor institutions, which we already talked about. The whole idea there is changing the model from an illness model to a wellness model and beginning to think of those things differently a bit in life. When you look at the pie chart on the next page, what you see is this notion of the three aspects of what we care about. So yes, we care about clinical excellence, but we also need, in a collective manner, as we think about health and well-being, to think about social determinants. And oh, by the way, given what we are and who we are in our communities, also to do some activities as an anchor institution. Again, nobody has unlimited resources, but we really need to think in all three of these areas. It's not a resource map. Most of our resources still go into clinical care, but we're putting more emphasis and more respect to those items and making investment in those items more than ever before. We have initiatives in housing. We could talk more about that, the needs for housing. We've done some partnerships with some of our banks and with LISC and the National Equity Fund relative to stabilizing these LIHTC, low income, boy, I'm going to forget the acronym here today, low income tax credit houses. Hope that's right. And we're really trying to, the process there is getting residents to home ownership, and we also created a fund for our own families that work for us. Also, lead paint, huge issue. So we've really been beating the drum against landlords and lead paint not taking care of lead paint. And then also just working real carefully with the Green and Healthy Homes Initiative. I talked a lot about infant mortality. Again, this was an issue that plagues Ohio, plagues other states. And really, a few years ago, our obstetricians kind of in their heart of hearts knew there were issues, but they really didn't respect the magnitude of it. So we really started a number of years ago to really put a lot of emphasis. And we're having an impact. It's hard. It's difficult work. But again, it's a lot of screening. It's a lot of referral to the right programs. It's making sure that we have home visits and that we have the right type of services. And so we've seen good luck there so far, but we've got a long ways to go. I talked about economic development, the importance of economic development. Again, we're interested in economic development not for financial reasons. Of course, we don't want to lose money, but it's mainly this idea of creating well-being, creating jobs, creating a healthier community. And so we've been able to access a number of funds. We've been able to do a lot of things. And really what our work becomes is more community-based work. And the next slide just shows this notion of, creating communities. So people will say to us, well, who are you people? Are you healthcare people? Are you real estate developers? Are you social agencies? Who are you? And we say yes. And usually they say that not so nicely, by the way. And the idea there is just we are about creating community and this notion of try to create the communities we all want to live in. And so whether you want to look at, some of the work, the Project for Public Spaces, the book WellBeing, some of the articles about Atlantic, some of the work that people have done about, steps to a stronger city. This whole idea that placemaking matters. And you may know this thought of placemaking and about creating great spaces and how do you create spaces and how do you create healthy communities. And all this stuff matters, including the arts, including parks and vitality. And we see it all in this whole continuum of health and well-being. And it's led us to have a lot of success. And I think the next slide talks a bit about kind of how that all works and kind of the success through collaboration and some of the projects that we're doing. I think your next page is just a kind of a riverfront shot of Toledo. It does the green, our color is green, so that shows our system offices there. So there's a vacant steam plant on the water in Toledo. The building behind it that says ProMedica, that's our first 1,000 employees. And the building next to it is the next 1,000 employees. So we're moving these 2,000 employees, renovated a park, kind of that open area on the land is something called Promenade Park. We sponsor a series of concerts and a variety of things. It's this whole notion, again, of economic development. The next page is really this notion of kind of the downtown revitalization. One of the things we thought a lot about when we went downtown is people said, well, when we were moving downtown, we were being criticized for, taking, river and parking and all those things. And really people said, you're going to be like every other company. People are going to drive in from the suburbs and drive home. And we said, no, we're not going to do that. So we've really taken this to heart about our role. And one of the first things we got involved in is helping the city create a new strategic plan. But the idea there was if all we do is build shiny buildings in downtowns, we've really not done our job. So we really have to think about the health in neighborhoods. So we've done a lot relative to not only some of the projects here. You see the riverfront on the left. You see this retail center in the middle. You see the Marriott Renaissance on the right that we're involved in. But we're also right now working with the Baldrige Centers of Excellence approach on kind of a plan for neighborhoods. And there are cities that have great things going on in their downtowns, but their health of their neighborhoods continue to go down. Hard issues, longer issues. So kind of our things in the uptown area and some of the things that we're doing now are really directed toward what do we need to do, boots on the ground in neighborhoods to come alongside of neighborhoods and try to provide some resources that will enable people to, move forward in life. The next slide talks a little bit about some of the economic investments we made. Bottom line, again, love to say we thought this was going to happen, but our move to the city really spearheaded a whole variety of moves. Could be as high as $1 billion of moves. Some of it that we had a role in, and that we, again, as an anchor institution and buying and flipping things to developers and participating with some folks on projects. And really what it means, again, is, economic vitality matters, especially when you're thinking about, people's health and well-being. So again, we take the anchor mission alignment idea, and it's really broadened. So over the last 8 years, we think in terms of this economic and community development. We think a lot about areas of education and job creation, a lot about trying to kind of create an inclusive employment area, personal finances, looking at some of the issues relative to, determinant of health screening and what we can do there. What we are going to do next with social determinant screening is to screen our employees. And our idea there, again, is if you screen employees and take interactions with employees, you'll have healthier, more well-being, more productive employees, but also we believe it'll lower our healthcare costs. So if we improve that, we believe this is something that many, many companies would like. It's actually baked into our strategic plan. So if you looked at the next page and looked at strategic investments, this notion of who we are and what we are baked in our strategic plan. the slide here that talks about ProMedica 2020. These are our strategic principles that we're committed to. And as you will look down those principles, you will see that the fourth principle is that we plan to be a kind of a national center, a national example for social determinants. I will tell you, our board has been extremely committed. From the early days, we didn't talk about it so much, but it's built, and they're very strongly focused on social determinants. Our doctors, surprisingly, have been very strong advocates of social determinants. Our staff, it's kind of a mixed bag. We kind of have to talk about it all the time. They get it, but then new people come and they go like, "Why are you doing this? And why don't you give me another nurse? Or why are you spending money on this?" So I have to tell you, that's a little bit more of a challenge with us. But the idea there, again, it's broken into our vision as well and embedded in our vision. And then lastly is this just, if you're a Malcolm Gladwell fan, this is just a quote from Tipping Point. Really, if we're going to change communities and if we're going to change beliefs and behavior, it's really up to us to kind of create the communities we want. And that's where, people flourish with health and well-being. And it's really this notion of us being able to do in healthcare what we perhaps haven't done in the past. We have resources, we have people, we're nonprofit, we're mission-based. And I will tell you from a ProMedica perspective, the more we do, the more we realize that we need to invest more and do more because we know it's the right thing to do, and now we see it's very impactful. So with that, we'll move through a lot of slides very quickly. Happy to take some questions.
Well, thank you so much, Randy. That was really an outstanding presentation that walked through a lot of specific examples of things that can sometimes be very vague. So we have a number of questions, but to remind you, if you can type in the questions in the question box you see on the right side of your screen, but we'll get started for at least a few of them. So one of the first questions is, do you have an accountable care organization as part of this healthcare system? And if so, if you look at the impact of your initiatives on the population that is served in accountable care organizations specifically?
Yes. So we have two things that we have accountable care organization that we have, I want to say 60,000 lives in. We also have our own health plan, and in broad terms, we have about 600,000 lives. Half of those are dental. The other half are like Medicare, Medicaid, traditional, commercial. And then we have about 200,000 lives in Medicaid. So we can tell when we do this social determinants, not only do we have the provider piece, but we also have the insurance piece because, again, with 200,000 lives, we're actually statewide in Ohio for Medicaid. And so this is what our health plan, has been doing for years. And so what we've been talking to the state of Ohio about is doing more of an intense project around social determinant screening. So it really ties in. I mean, when we begin to think about accountable care, when we think about, value-based care, as we know, I mean, this is really true. When you think about, if you want to call it population health, this is true population health. This is really looking at all the pieces and parts. So the short answer is yes, we connect the dots through our health plan, through our accountable care organization, and we're working harder and harder to embed these social determinants into their work and then understanding what that work does relative to clinical outcomes and cost.
Okay, thanks so much. The next question is around gentrification. One of the criticisms of large-scale efforts like this, particularly in revitalizing downtown regions, is that it does make the community better, but it forces out the people that have traditionally lived there. And I'm sure you've been asked that question, so let me see what your response is in the effort you're leading in Toledo.
Yes, so we've seen that in many communities. We visited communities where we've seen it in action. We've seen where as downtowns have expanded and new shops and people that don't have means get pushed further and further out. So that's why, as we looked at some of these other initiatives, and I'm going to tell you we haven't figured out, but having the eBide gift and the eBide neighborhood, that would be a neighborhood that would typically, see development. So right now we're working hard, got an inner city grocery store, jobs, appropriate level of housing. We're doing a lot to study housing and available housing. And we're well aware of it. I'm not going to say that we've figured it out, but we're really concerned about making sure that we can embed people and resources in the neighborhoods and help them, perhaps change, but not, require people to move out. So it's a balance here. But again, as we've said all along, if all we do is build shiny buildings in our inner city, force people out, we really haven't done our job, and we're just going to lower the health outcomes anyway, and that then we failed. So we're aware of it. We're working on it. I would point toward the eBide work, the $50 million, the LISC money that we've had that we're hoping to use, some of the other initiatives. So we're hoping to be able to address it. And all I can say is ask us that question again in 2 to 3 years, and we'll tell you hopefully how we're doing.
Well, thank you. A question about, could you describe a little bit more about the partnership with AARP and what the audience for that particular partnership is and how it's serving older people in the area?
Yes, so we're doing these national hunger sessions with the USDA, and it was ProMedica and the USDA. And at one of the sessions, we got approached by the CDC and AARP, and I think the person who approached us from the AARP said, "We want to be your best friend." And that led to a series of discussions and partnerships. So AARP is very focused, of course, on hunger in seniors. We're very focused on hunger overall. And so we said we need to do 3 things. We need to disseminate, we need to create awareness, we need to do research advocacy, and then we need to disseminate, information to people about what they might be able to do in their own communities. So we started with the 2 organizations. If you go to the Root Cause Coalition website, you will see, I think last week we went to 50 or 51 members. We have a national platform. We do webinars and advocacy. We're trying to be kind of a place where we can share social determinant information. And we're really trying to focus on different sort of segments, including seniors. So we're working in the space. We're not quite where we want to be yet, but primarily our partnership as we formed it and we've been working on it is to create best practices, create research, and then create awareness. So that's the kind of the focus of the website. That's the focus of our national sessions. And I think what you'll see is continue to provide resources to people that want to address senior hunger.
Thank you. A question from a health foundation, and of which we have several on the line today. What resources would you suggest if they're part of an organization that is looking to shift the way that they provide funding to health and other aspects to include more of the social determinants of health? Where would you start? And maybe add an additional question: how would you help trustees of foundations to understand this issue better?
There's been a variety of dialogues, participated with the Governance Institute a few times as they've brought trustees together. About a month ago, I was at a health system retreat out in California, and the idea there was to expose their trustees to this idea. And part of the question is, where do you start? So, for us, we started 8 years ago. We started in hunger. I think the idea there is to begin to talk to people about the issue. I think a lot of it is the why of all this, why we believe this is the right thing to do. Begin to have people think about social determinants for the first time sometimes, and then find a place to start. We started with hunger, not on purpose, but that's the space we were in. And it actually, for us, was the right place to start because, again, people could tangibly give people food, and it gets more complex from there. And so what I would say to people is to begin to think about, how do you begin to have this dialogue? How do you begin to talk to trustees? Where would you want to start? Do they embrace the idea? And oh, by the way, are they willing to commit some resources? So we talk to our board about that a lot. Well, okay, you like this, so you're willing to commit resources, both on the social determinant side and on anchor institution side. So I think I would start there. We last month we do case studies for a lot of our board meetings. We had breakout sessions around social determinants. Again, I think it's just getting that dialogue and getting people's thoughts. But that's probably where I would start.
I think this is probably a follow-up to that question, but if you don't have the internal leadership for this at the CEO level, truthfully, probably, is there anything you can do to move this forward, or is this something that really is essential to be driven from the top?
You know, we've had some folks that have come to our root cause meeting and have had the same sort of discussion. And I know a person who came to the first two sessions said, I need to get my hospital president to this meeting. How can we do that? And one thing led to another, and eventually he was able to convince him to. Actually, it was I went out to their board retreat and talked to him. And I think I would suggest that especially healthcare, very competitive folks, I would begin to share information with your C-suite folks about some of the work that people are doing in social determinants and try to spur on a conversation about it. Because there's some great articles written. I think you can look at a lot of the healthcare magazines and some of the resources. And this idea that people are doing this work, and B, it's kind of a part, depending on what their perspective is, it's really part of this, as we talked about accountable care and population health, and this is the next level. And oh, by the way, I can tell you from a system standpoint, it tremendously impacts positively on your brand. So I would look, if you don't have a responsive C-suite, I wouldn't give up. I would just think about ways, subtle ways, maybe not so subtle, on ways you can educate them and maybe try to get in front of them resources, or if you can get them to a meeting, that would be great.
Well, unfortunately, that's all the time we have for questions, but I want to turn back to you now, Randy, and ask you for your final comments and words of wisdom to our audience.
I think I kind of just look at our journey, and again, we didn't, never plan to be in this space and this point. We started doing something that we thought was right for our communities, and kind of the idea that if we didn't do it, no one else would do it. And now what we find is this is really kind of the in our minds the next evolution of healthcare. And I think for anyone that's not done it or thought about it, I think just starting somewhere, I think you'll be amazed at what you can do. There are tremendous resources out there. I think 5 years you might have been cutting new ground, but today I think there's a lot of great resources out there you can tap into. And I think just the notion of strongly encouraging to start. When we talk to our board members about it, this is why they're board members. I mean, especially when you think about people giving their time and effort and treasure to try to be impactful in their community. So I would wait. Sometimes we have to be a little bold, but I think this is the right direction. I think it's the right direction for healthcare. I think it's the right direction for employers. And I think if we can begin to continue to get the right research, that in 5 years, we could see a lot of these foreign sort of ideas regularly embedded in healthcare institutions and a lot of our employment venues.
I want to thank Randy Oostra, who is the president and CEO of ProMedica, for this outstanding presentation today. And we thank you and all of those who work with you for what you do to make life better for older adults and also everyone in the community in the Toledo area and beyond. I also want to thank the 5 Funder Collaborative, which includes the Commonwealth Fund, the John A. Hartford Foundation, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation for their support of this work. And to our collaborators at Grantmakers in Health, who have been part of this project with us all along. We will be making this presentation available to anyone who wishes to view it later, including both the slides and the audio. Please watch for a rebroadcast link on our website or contact Grantmakers in Aging at info@giaging.org. And please join us for our upcoming webinar on May the 9th at 2 p.m. Eastern Time, and join the Eisner Foundation and Encore.org's Generation to Generation campaign for a webinar on effectively engaging older volunteers in youth-serving nonprofits. You can find more information about this on the webinar page of our website. And finally, I want to thank all of you for participating in today's webinar. Have a great day.